So I'm on secondment with VicTag. I'm actually an oncology pharmacist currently employed out at Eastern Health on a substantive basis. And Adam Chapman from the department has been working with me on this project. I have to say that the project's funded by the department, and that's the business side of things taken care of. So we'll get into developing an audit, a chemotherapy audit toolkit for Victorian Health Services and what that looks like and what that's all about. As soon as I figure out how to make this thing work. That'll do it. So, as we've spoken about probably for some length today, the two main incidents in chemotherapy in the last couple of years in South Australia and New South Wales have both greatly influenced where this project's come from. And it's important to understand a little bit about where the project's come from to understand where it's been going and what's been going on with it. Big parts of both of those incidents, as we've touched on before, were failures of governance and communication, and they are vitally important things in ensuring that we give good, high-quality service to our patients. In terms of the Victorian response, the department surveyed health services across the state on 2 occasions to try and understand what quality processes were in place during this prior to this time, to have a look and see if there was any gaps in our quality systems and to see what could be done to try and improve them and what we could look at. So survey 1 went to the Integrated Cancer Services, who then disseminated that onto health services, and 27 health services provided responses. The response rate was okay, but we went then on with the second survey to services that were providing infusional chemotherapy, and we got 43 public and 26 private providers providing feedback. And the main takeaway point that the department got out of that was that 27% of services perform retrospective auditing of chemotherapy in some shape or form. Having been talking to a lot of different health services about what that auditing means, I can tell you that that is a very variable measure. There are all sorts of little bits and pieces that are happening, and the threshold to be able to say you're doing some retrospective auditing on chemotherapy isn't very high. Some places we're looking at whether documentation has been made on changes and whether there was anything put there. Not the quality of it, not whether it was a reasonable thing to do, just whether somebody had written something at all. Some services had quite good models and they were examining variations and looking at the reasons behind them and whether they were appropriate and getting their own clinician groups to discuss that. And that's what I think is a very good model. So I've already focused on the poorest use of regular auditing and electronic prescribing management systems. We'll cover that in a little bit in a second. And the rest of it was things that the hospitals were doing quite well. So how do you respond to that? What do you look at to that? Auditing is a very broad topic. What do you audit? What limitations do you have around what you can audit? First and foremost in my mind is human resources. We're all incredibly busy people. We don't have enough time to spend 3 weeks auditing as a full-time job. And also ease of data access. For those of us working in paper systems, it's an interesting task, but even in electronic systems, the reporting that we've got is limited by the tools at our hand, the electronic prescribing system that we use and what that supports. And being able to understand what you can get, what that means and how you can use it is a very interesting thing in itself. It's not always apparent that what you're getting is what you think you're getting. So to me, the biggest piece of this is it's a conflict between a protocol, an evidence-based guide for what to do when we're presented with a patient versus personalisation. And it's something that oncology's held very dearly for a very long period of time. And the point of an audit isn't to come down and say you can no longer personalise. That's in no way or shape what this is supposed to be. So you're trying to manage that to ensure that personalisation does occur, but it occurs on a discussed and agreed basis and that people feel it's appropriate. And it's also important to remember that while we have the context of those 2 medication errors, it's important to think about the broader quality context of chemotherapy as well. I can go out and design a tool that's going to prevent those 2 errors from ever happening again, but does that really serve the system? Does that really serve the patients from all the other types of failures that we could see in our systems? So it's important to remember that what we're trying to prevent changes over time, and it depends on the context of care. So the development approach towards the tool has been to focus on electronic prescribing systems for the first 6 months, and that's been looking at systems that have been used in Victoria at this point in time. There's been an extensive round of consultation with sector, mostly by approaching oncology pharmacists to see what's been happening in that space in health services already. We're in the middle of an extensive piloting phase to understand what we can do to support this type of auditing, and it's envisaged to fit in as part of a wider quality framework that will help hospitals to understand, how health services to understand some best practice methodology around how they can manage these types of things. So far we've formed a steering committee and a project reference group, and I'd like to say that probably about half the members of both those committees are in the room today, and they are actively involved in the sector. We've analysed current sector approaches. We've got the most established approach that we've found in Victoria was found with CHARM down at Bowen, and they were a very good best practice model that we've found so far. We've then gone and taken that approach and tested it at multiple sites and confirmed that it can be used across different CHARM systems. And we're following up with users of other electronic prescribing systems to investigate approaches that may mimic this approach. So we're looking into Cerner, Epic and ARIA as systems that are currently actively being used. An interesting part of the work has been to try and figure out who's using what in terms of a EPS. And as you can see, there is a significant percentage, almost half of health services in Victoria, and this is looking mostly at the public health services, that aren't using anything in an electronic space. CHARM looks to be quite a dominant user, although the results are somewhat skewed by a couple of regional areas that have a lot of health services, some of them quite small, that use CHARM. And it's been an important part of their hub and spoke methodology to some extent. And then you have a little bit of ARIA, Cerner and Ascribe in use as well. You can see that in the future where people have committed to moving to as well. So we're moving slowly away from paper, but it's a process that's taking some time for the reasons that we've all discussed and we all know quite well. So in terms of the audit tool progress to date, so as I've said, we've piloted the CHARM version at Barwon, Latrobe, Peter Mac and Slades via Icon. We've also had discussions with some other health services and they've had a look at it to see what can happen with it. We've also had some discussions with Queensland Health who've been interested in it too. In terms of Cerner, we're trying to explore what the appropriate report, Epic the same, and ARIA we found that we don't have anything that we can use when we're in the process of trying to get a customised report that we can use. Mosaic has although it's not currently implemented in Victoria, we have found a mature approach in New South Wales. It's very good. In terms of other electronic prescribing systems, that's an interesting question. I'm more than happy to discuss with anybody if they do have anything else that's being used and try and find them to help them to find something that's appropriate. We would be looking to release the methodology, not just the tool itself, so you could understand or provide that to a vendor to help you to get somewhere. In terms of how the tool itself works, in terms of CHARM anyway, what we do is we get the electronic prescribing system to produce a report of all the variations that occur in chemotherapy. And basically, this then undergoes a filtering process to try and decide what could go back to a multidisciplinary meeting or a tumour stream group of clinicians. It's important to note that the tool isn't going to produce anything that's going to go to the department at this stage. It's an internal tool for health services to use on their own to regulate their own behaviour or to provide best quality care for their patients. So there's an automatic and manual filtering process to try and streamline that for people. And then there's a discussion on a tumour stream or MDM. So some of that I already said. The other big thing about it is it's impossible to get an electronic tool to determine the validity of variation to care. That's the personalisation bit of it. It's an impossible thing to do. So we need to rely on the clinicians from each organisation to be able to do that themselves. And the quality infrastructure surrounding that tool may be different in different setups. At a small regional centre, it's going to look very different to what it might look like at somewhere like Eastern Health. So there's going to need to be some customisation or some flexing of the structure around it or the tool to the structure around it to help it to work in your scenario. I'll use the example of the charm variation report. This is an example of the report that you get. This is a far bigger slide of the same thing. So in this example, you can see that it gives you some data on a change that's been made to some chemotherapy. And you get some information out of that. Now, it's not in a very parsable sense for an electronic system to actually work on that, and that's part of the thing that the tool provides. It's interesting to note that although it says neoadjuvant up there, that data is actually programmed in by the people who create the protocols in the system. It's not part of the system itself. So while you can sometimes, and depending on how the system is set up, filter for that, it can't always be done, it can't be relied upon. So the tool itself at this point in time filters for cycle 1, so the variations that occur at the start of treatment, and it filters for supportive care medications as well. So in the example that we had, 80%, and this is proven true through a year of treatment over 4 tumour streams, 80% will automatically be excluded from the report as being not relevant for these people to talk about. There is then a manual filtering process that occurs, and these are some guidelines that have been discussed by our project reference group. They may change as we use them a bit more out in practice. And then a discussion needs to occur about why these changes were made and whether that's something we should continue to do. The follow-on from that is whether a report should be made to a head of unit or quality department. That's to be made on an institutional level, and we're not sure what we'll recommend yet in that space. The interesting question is paper systems at the moment, and we're struggling with this. Limited resources is a very big problem, so we're aware of that, and we're trying to figure out a way to provide the best bang for buck, is really the question. So how do you sample? So whether you do it randomly, whether you do it prospectively or retrospectively, whether you're focused on tumour streams, so you decide this year you might audit breast, for example, whether you capture an amount per prescriber, although that leads to some interesting issues as well, given that the person who's in charge of the chemotherapy regime may not always be the person who's entering into the electronic prescribing system as well. So there are some variables that you can find around the places. At the moment, we're thinking about retrospective is probably better. Prospective will mean that you're limited on only the first person that looks at it, and probably focusing on tumour streams, but we're yet to see how this will play out. I've mentioned the best practice quality framework before, and I'll be looking at covering the spectrum of from evidence to patient and what process information goes through to get there, and who should be looking at it as part of those, part of those steps. It'll also look at managing variation. So if somebody detects a variation, who do you need, basically what escalation pathways, if we go back to the last talk, who do you elevate, who do you escalate to? And establishing appropriate review pathways for the tool as well. Some challenges that may occur. So when it was first thought of, benchmarking was something that was thought of. That's not something that we're looking at for the moment. It's very difficult to do, even across the same electronic prescribing system, because of the differences in the way that people program their own protocols in. What might show up as a variation in one organisation might not be in another, and you might lead to having the same level of variation naturally per patient, but one system might report 20 and the other 50%. And therefore that doesn't provide you a target. And you could even question, what does that even mean? Are we more appropriately managing our chemotherapy for our patients if we have a higher variation amount rather than a lower? I've already discussed the second point, and then there's the adaptability to each health service, which I've covered in a little bit as well. So I'd like to open up for questions if anybody has any questions.
Yes, so this one's just around looking at the paper-based or electronic-based. So the question is around paper-based tool for use in regional areas, or how you're managing that in the regional space, and it also referenced the hub and spoke model, so whether there's any interplay with that.
Yeah, so we've had a bit of a look at that. We have some people on our governance groups that are from regional spaces, and the practice is a little bit different. In some spaces, the medical oncologists exist on a regional basis, and as Rob showed earlier, they do travel around to other sites, whereas pharmacy and nursing can often be somewhat siloed and work at that particular institution. So there would need to be some work to try and work out what the best place for that data that would be the output of the audit to be presented one would suggest that it's probably wherever those patients are being discussed on a multidisciplinary level.
And we might also just go back to organisations being benchmarked. You mentioned that one. That was a question that came up a bit earlier. Do you have anything to say around that?
Not necessarily more than what I've already said. If there's a bit of that you like clarification, I'm more than happy to answer that. But
I think that covers it.
Yeah.
So, Catherine's.
Oh, sorry.
Thanks very much, Shaun.